It is quite new for you. Okay, that's nice. And Nicolas, some questions? We have some nice discussions and interactions. It's always better. So screening on asthma. Well, this is a patient who actually died from a severe asthmatic attack. And this is some slides from some bronchial biopsies, some specimen from under microscopy, light microscopy, showing patients who died from severe asthmatic attack. So this is a slide from the bronchial wall, actually, and it demonstrates here the massive increase in airway wall, most importantly because of airway inflammation. And you can see that there's always no lumen, airway lumen left here. So this patient would have severe breathlessness, really have enormous amount of work of breathing before she died because of this asthmatic attack. It also nicely demonstrates what's going on in the airways. We see here there's a small increase of the picture. That there's a lot of airway smooth muscle in this airway wall, which is increased, which is thickened, and which is also constricted, also contributing to this airway narrowing. And here you can see a massive increase in inflammatory cells, airway edema, mostly eosinophils, a little bit dependent on the type of asthma you have, but an enormous increase in the airway wall, causing almost no airway lumen here. So it's very difficult to have breathing through this airway. So this nicely illustrates what we're talking about this morning. So asthma is still a disease which you can die of. It's in the Netherlands less than, let's say, 10 or 20 years ago. But still, it can be a dangerous disease. Of course, when it's diagnosed well and it's treated well, you can live very well with it, have very little symptoms, and a good quality of life. But then diagnosis and a good treatment is very important. So we will have details about good diagnosis and treatment in this lecture. So let us first ask the question, what is asthma actually? What are we talking about? And there's one professor in the United States who had a very nice definition. He said, asthma is like love. Everybody knows what it is, but no one can define it. Professor Nicholas Gross. Well, it's not that bad. It's not very easy to give a good, accurate definition of asthma. And well, you already have some information on asthma, so let's start with some interaction here. Is there someone here in the first row? We can have some ideas and try to give this definition. Should not be completed, or we can help each other. So what kind of symptoms can we have in asthma? What characteristics of asthma? Inflammation. Shortness of breath. Yeah, very good. Wheezing, also an important symptom of asthma, important complaint. Breathlessness. Okay, other symptoms which we can have, other complaints in children or adults. Coughing, that's not very specific for asthma, but can also be another symptom. But breathlessness and wheezing are the most important. I think that's true. Well, there is a pathogenetic, pathophysiological basis for asthma, which is airway inflammation, which is very important. And when we remember the last slide we had about the patients who died of asthma, there's another pathophysiological characteristic, which is very important. Think about the constriction. Yeah, excellent. So there's increase in airway smooth muscle, and it just can constrict on various specific and non-specific stimuli. So the Global Initiative on Asthma Working Group has, I think, a very fine definition of asthma. They say asthma is a disease with symptoms of coughing, wheezing, dyspnea, or shortness of breath, characterized by a variable but reversible airway obstruction and based on chronic airway inflammation. So it's a variable airway obstruction. So you can have periods in which you almost have no symptoms, and there can be periods in which you have severe symptoms because of allergic stimuli or non-specific stimuli. Is there someone who can give an example of a non-specific stimuli which can trigger bronchoconstriction in asthma? Cold air. Excellent. Exercise is also a very important trigger, especially in children, who often gives complaints. Some other triggers, you know. Smoke, cigarette smoke, or diesel from traffic. Yes. So all kind of, also cold air in this type of the year. Changes in temperature, quick changes in temperature, going from inside a house or outside a house to the cold air, or from cold air to warm air, all can trigger the airways to constrict. We call that non-specific stimuli, which can give airway obstruction. But very characteristic for asthma is that it's very variable. And the basis on all these features is this chronic airway inflammation. So here, a normal alveole, which has been enlarged. You can see here the airway smooth muscle, which is going around the airways in a circular way. And if these smooth muscles contract, you can imagine that it constricts the airway. You can see it here. Beside that, in comparison with a normal airway, you see here the swelling of the bronchial airway wall because of the airway inflammation, and also the mucus, which is here in the airways. Because that's another feature of asthma. You can have production of airway mucus, and you can have a productive cough. So if we look into the airways, for instance, by bronchoscopy, you can see normal bronchus in the upper side here, and here we have, you can see inflamed bronchus, for instance, in a patient with not stable asthma. So that's another pathophysiological feature which we are talking about. Well, cough is one of the symptoms of asthma, can be one of the symptoms, but it's important to realize it's not very specific for asthma. So there are various other reasons for coughing in children. Is there someone here on the second row who can give a course for coughing in children or in adults in this type of the year, which is far more important than asthma? Can you think about a reason for coughing in children or adults in this type of the year, which is far more important than asthma? It's a source for coughing. That's difficult. That's not a complicated question. Yes, of course. Viral infections like influenza or rhinovirus or viral influenza virus. A lot of viruses can give respiratory infections of the upper and lower airways, are an important source for coughing in both children and adults. So mostly coughing is not because of asthma. It's important to realize that. It can be, but it's not very specific. And people did a very interesting investigation in children. They asked themselves the question, how often does a healthy child cough? And in 41 children, they monitored coughing. And these children have no signs of a respiratory tract infection. And the result was, during the day, that 1 to 34 times children cough for 24 hours, with a median of 11 times. So that's quite a lot. In adult, it's perhaps somewhat less, but coughing is, this has a good effect. This is a normal process in the airways. I've heard some clever girls here on the first row. So. What do you think? What would be the physiological sense, physiological meaning of it, of coughing? You're right. He says you can produce sputum of mucus, slang for the airways. And that's right, because coughing has an important cleaning, characteristic, cleaning function in the airways. So it's very important. Coughing is a normal process. Well, we talked a little bit already about wheezing. Wheezing is a very important symptom of asthma, but also wheezing is not very specific for asthma. It's important to realize that there are several other reasons, several other diseases which cause wheezing in children and adults. For instance, the airway infections, we already talked about it, but also cystic fibrosis, for instance. Do you know that disease? Mucofiscidosis or Dijsselbloemziekte, we call it in Holland. It's a genetic disease with very tough sputum in the airways and a lot of bacterial infections. It's just not very common. This is also a source for coughing. Also immunodeficiency problems and also heart diseases can cause wheezing in children. And there are also some specific infections like Kinkhoest, Bordetella, or Mycoplasma, or tuberculosis, which of course also give wheezing. Now, how can we discern breathlessness in people? Because we've seen breathlessness is also one symptom of asthma. People from the third row, they also look very clever. So start with girls always are more clever than boys. You have an idea, how can we see breathlessness or shortness of breath in people? Children or adults, doesn't matter. Spirometry, that's the lung function test. Yeah, you can see it that way, but I just mean by looking to a person, how can you discern breathlessness? How can you see movement of the chest? Yeah, that's right. You can have retractions. You know that word before? Retraction is someone has an inspiration and then the chest goes downward. So retractions is indeed a sign of breathlessness. Now think about the frequency of breathing. When a patient breathes very rapidly, with a high frequency, that's often a sign of breathlessness. Other signs? Color, perhaps? Let's say something. The voice there? You can discuss with your neighbor. When I'm thinking about color, does that tell something? Well, often when you see it in the color, it's not very good for the patient. Because cyanosis, or a blue color, because desaturated hemoglobin, shows you that you have a shortness of oxygen. That's a sign also of breathlessness. That's a rather late sign, so that's not very good. Okay, shortness of breath. And in children, we have the neusvleugelen. I don't know how to translate it. There are quick movements of the nostrils. In children with a high breathing rate, with a lot of shortness of breath. Respiratory rate is increased, tachypnea we call it. Use of accessory muscles. You mostly see that in adults. Patients with emphysema or COPD, they often lean to the table or something like that to use their accessory muscles for breathing. Well, what are the consequences of asthma for daily life? It's nice to think about that for a while. Well, they're quite large. We already discussed it. There are complaints of coughing, wheezing, restlessness, sputum expectoration. That's not very pleasant for a child or an adult. can have a lot of allergic complaints. You come in an environment with a dog or other pets for which you are allergic and immediately get a runny nose or shortness of breath or coughing or dyspnea, restlessness. But that's not very nice. We also talked about a specific bronchial hyperresponsiveness, so hyperactivity of the airways to a lot of triggers which can generate symptoms in daily life. This is very unpleasant. So cold air, fog, smells, perfume, fluoride in the swimming pool, which, well, it's not very nice to have that. What do you think about nocturnal complaints? Normally in asthma, when you have, when it's unstable, most of the complaints come during the night. So the child wakes up because of breathlessness or because of coughing. And it's also waking up the parents, of course. So that's a huge effect on the whole family. So nocturnal complaints, this really has a big effect on quality of life. Diminished exercise capacity. So the child normally plays football, but during an asthmatic attack, well, he can only be in the football playing for some minutes, for instance, and then has to use some medication. So it really affects daily life. Urgent care visit, and there are more complaints. Well, use of all kinds of medication which can produce side effects. So that's really has a big effect on the quality of life. Nowadays, the level of asthma control is the thermometer, which is used for the titration of treatment. So how much complaints you have, the stability of asthma really drives the therapy in patients. Several years ago, we also incorporated the severity of asthma in that. But it's quite tough to define severity of asthma. It also goes on. It increases and decreases. So nowadays in the guidelines, the level of asthma control is really drives the therapy. There's also written in the revised guidelines of asthma in children in the section of pediatric pulmonology in 2008 in this country, which is also quite similar to other international guidelines. Treatment is guided based on the level of asthma control and no longer on the severity of asthma. It's important to remember that. Now, how good is asthma controlled when we look to the population of children? We did that in our own population, and out of 12 children with asthma, aged 6 to 16 years, 35% girls and 66% were atopic. In 3 centers, Helmond, Sittard, and here in Maastricht. And we used the GMAT criteria for asthma control. And we're quite disappointed that asthma was not well controlled in at least 55% of our children. Only 8% had an excellent control, and 37% had good asthma control. Well, this is quite similar to other surveys, international surveys, mostly asking patients by telephone contact. But we thought, well, this is a specialist population, well controlled with regular visits to the outpatient clinic, so perhaps asthma control is better. But it was quite disappointing to see it was not so well controlled. But there are several reasons for that. We do not all, we cannot cover this topic in a whole in this lecture for 1 hour. But some important reasons are that patients perhaps do not always discern their complaints very well. You have so-called poor perceivers. One other reason may be that we don't measure this airway inflammation, which really is the most important factor, most important cause of asthma. We don't measure it during our monitoring of patients, and this is not. We are not titrating treatment because based on airway inflammation. So perhaps that's also one of the reasons that asthma is less well controlled than we should wish to be. How often does asthma occur? What's the disease prevalence? Well, there are a lot of changes in prevalence, for instance, in many countries, but also changes between countries. These are data from Netherlands, from the general practitioners. And as you can see that in the 70s and the 80s, prevalence in children was quite low, but a dramatic increase, 4 to 5-fold increase in prevalence occurred from 1987 to, let's say, 2000. And after that it stabilizes. We don't know, we don't know for sure what's the reason for this. It can be in part some more intention for asthma in children, but certainly has to do with a real increase in prevalence. Because of allergic triggers, because of pollution, we are not for sure. So this is a picture from showing the differences in prevalence worldwide. You can see that the prevalence of asthma is, let's say, more than 10% in countries like Australia and New Zealand and the UK, whereas in Africa, the regions where asthma is only prevalent in 2 or 3% of cases. So really huge differences between countries. Worldwide, there are still children and adults dying because of an asthmatic attack. It's important to realize that. So what are the causes of asthma? Well, we know there are genetic causes, but multiple genes are involved, so that's not very easy to unravel the pathogenetic factors of asthma. A lot of inflammatory genes and oxidative stress markers and genes are involved. And we also know that environmental factors like cigarette smoke, airway infections, perhaps RS, virus infections, air pollutions, and allergy all contribute to asthma pathophysiology. And also these gene-environment interactions, as in many other diseases, are important for the final development of asthma. Well, there are some immunological processes which are important. It's about Th1 and Th2 skewing and allergy. Th1 are T helper 1 cells and T helper 2 cells. Well, we have uncommitted CD4 positive cells, who Th0 cells, we call it. And they, in contact with bacteria and viruses, they can develop to a Th1 cell producing interferon gamma and IL-2. And there can be a development towards a Th2 cell line by exposure to parasites or allergens. And these T helper 2 cells are thought to be important in the development of allergies. They produce IL-4 and IL-5 cytokines. But reality is even more complex. We know we have regulator T cells, which are even above the T helper 0 cells, and they also can regulate the differentiation of these T helper cells. Well, a part of this inflammatory process, you can see the antigen-presenting cells at the left side, which in contact with certain antigens or allergens can stimulate the T helper 2 cells. And these can produce IL-4 and IL-13, which stimulate the cells to production of IgE, so allergic antibodies. And these allergic antibodies can react, for instance, with mast cells, which in contact with these pathogens can release a lot of inflammatory mediators. They do a whole cascade of inflammatory reactions. They produce histamine, leukotrienes, prostaglandins, cytokines. And on the lower side, you see the IL-5 cytokine, which can stimulate eosinophils also to the production of these inflammatory mediators. And finally, you get an allergic reaction. We have fast, early allergic reactions, but also very delayed allergic reactions. You have the development of an atopic disease. Now, a very simplified scheme. Reality is even more complex. A lot of more cells are involved. And this particularly relates for allergic asthma. We have not talked about non-allergic asthma. We know far less for non-allergic asthma. But to give you an idea about the type of processes which are involved in the airways. Well, we know that genes are important, so a predisposition for atropine asthma really has an influence. But how large is this influence? Well, this slide is about that. If you normally the risk for asthma in the population is 50%. So let's put the risk on asthma on 1. If your mother has asthma, then the risk of the child with asthma is 2 to 4 times bigger, more increased than if you don't have a mother with asthma. The influence of the father is somewhat less, 1 to 3 times increased risk on asthma. And when both have asthma, they have 2 to 4 times increased risk on asthma. So, showing that genes really have a big influence. But there are other factors. We also talked already about the environmental influences. One very important factor is cigarette smoke. When the mother smokes during the pregnancy, do you think what kind of harms can it do when a mother smokes during pregnancy? You know? What kind of influence are you aware of? Let's say on the second row. These very clever boys. Increased risk for cardiovascular diseases. The mother or in the child? Yeah, perhaps also in the child. It's very difficult to demonstrate that. Yeah, birth weight. And what is it, increased or decreased? Decreased during so the risk on dysmaturity is much larger. Dysmaturity is that you have at a normal gestation, normal malattermijn van de zwangerschap. Yes, the weight of the child is decreased. Normal period of pregnancy, that your weight is decreased. That's what we call it dysmaturity. Perhaps you can forget that. But birth weight is decreased. That's most important. Because in the placenta you can see all kinds of infarctions or during sugar smoking of the mother. There are other effects. When the mother has smoked during pregnancy, the child is born with structural small airways. So shortly after birth, the child already has a diminished lung function and small airways. So it really predisposes for more complaints during infections or wheezing. So it is important. Also, the risk on atrophy, hyperactivity of the airways is increased. In later life, the risk on COPD or blood emphysema. So it really has a whole life influence. Well, perhaps we can skip this. If you have questions or you don't understand anything well, please ask me questions. Well, this is a slide showing some of the influence of passive smoking. On the z-axis, you have the risk on wheezing, and here is the purple bars are patients who have passive smoking or are exposed to passive smoking. And the blue bars are those who have high or low house dust mite levels. You see that there's a massive increase in the risk of wheezing when children are exposed to both. When they're exposed to passive smoking, in combination with high levels of house dust mite, there's a substantial increase in the risk of wheezing. It's about 20 times as large. So environmental factors really have an influence on complaints in children. In summary, so the World Health Organization thinks that 50% of all children worldwide are exposed to passive smoking. And in others, we think that 20 to 30% of children are still exposed, which is much too high. They have structural small airways, they have less lung function after birth, and they have 30 to 40% more airway infections after birth. when they're in the postnatal period, when they are still exposed to passive smoking, they have a lot more airway infections. Middle ear infection, bronchitis, pneumonia, all kinds of airway infections. There's a higher risk of sudden infant death syndrome. Do you know that? It's unexplained dying of a child during the first year of life. Sudden infant death syndrome. There's a higher chance on meningococcal infections and a higher chance on hyperactivity and asthma. So this really is an important factor which is very difficult to influence because parents are not always very cooperative in trying to prevent this in children. Well, perhaps you've heard something about the effect of siblings and daycare on asthma symptoms. This is a slide nicely showing the risk on wheezing. It's on the y-axis in children of all kinds of ages, in different categories of children. The reference category, no daycare, no siblings. Children with early daycare and siblings, and children with early daycare and no siblings. And as you can see in the first years of life, the children who are exposed to daycare and have more siblings, they have a higher number of viral respiratory tract infections. So the question of all kinds of infections is much higher, and they really have a much higher risk on wheezing. But do they have a higher chance on asthma in later life? No. As you can see, at 6 or 7 or 8 years, these categories, these lines come together. So then the risk on wheezing and on asthma is comparable. So it's safe to let your child go to a daycare if you have more siblings in the family. It does not increase the risk on asthma in later life, but in the first years of life, of course, you have more complaints, but that's transient. Well, air pollution is also important. There are a lot of African cities, for instance, which have an increasing rate of air pollution, and also asthma is increasing in these cities. Well, we skip this. So we can ask ourselves, can we prevent the development of asthma? Well, that's not very easy to do that. There are some nice studies about this topic. I showed one study, the Canadian Childhood Asthma Primary Prevention Study. It's already executed in 2005. The aim was to investigate the effect of a multiple intervention study of 545 high-risk children. That was defined as 1 first-degree relative with asthma or 2 second-degree relatives with an allergic disease. And what was their intervention? They tried to reduce the house smog levels by bed coverings and by vacuum cleaners and by flat floors in the house. They removed beds in the house. They promoted the use of breast milk, and they tried to reduce passive smoking in the family, and also postponing the introduction of solid foods. Already started prenatally in children, and they're randomized in an intervention group and a control group. These are the results at 6-7 years, and you really see that it's possible to reduce the rate of asthma and allergy. The diagnosis of asthma by a pediatric allergist is even reduced to a relative risk of 0.44, so that's quite a big effect. So it is possible to reduce asthma, and when they define asthma in a different way, President Ruiz with bronchial hyperactivity, they show almost the same effect. So it is possible to prevent asthma in high-risk children, but it's quite complicated, and you really have to pick several factors. So here, all kinds of influence in houses, which can, in our environment, which have an influence on that, on asthma. You see the house that's might, in the right up corner, the pets, the dogs, and the cats, and the perfumes, the molds over there. So for high humidity in the house can also be deleterious. But is it really important is does it really contribute to prevent asthma when we sonate the house? Well, you can summarize all the studies on this topic by saying that it's not very effective to just put influence one factor. If you want to have a real effect, then you have really to influence all these factors together. Otherwise, you cannot prevent asthma. But if you do that, you really can influence allergic asthma. So sonation is useful, but then you have to take all factors into account. How to diagnose asthma? Is it very easy? Is it very complicated? What do you think? What do we know about it? Very clever rules here in the first group. What do you think? Is it how to diagnose asthma? Is it very difficult, or in children, for instance, or adults? Did you ever hear something about it? The girl over there.
I think it's difficult to diagnose it.
Mm-hmm. So, has someone an idea? How can you diagnose asthma?
Isn't it a breathing test first without an antihistaminic and afterwards when an antihistaminic is administered? And then calculate the difference?
Mm-hmm. So he says you can do a histamine provocation test. Yeah, that's one of the tests in the lung function laboratory which can be helpful. Not the first test, but it's possible. What you do then is let persons inhale increasing concentrations of histamine. Well, histamine is a substance which triggers the airways to constrict. So that's done in the lung function laboratory on the standardized circumstances, which you can imagine that's for children not very pleasant, because when you stop, when the lung function is decreased by 20%, so then a lot of children and adults already have quite a lot of complaints. So it's not the first test, not a very pleasant test to do. Also take a lot of time, because you have to wait until they have these 20% fall in FEV1, or in lung function. So it's quite complicated. But it gives you an idea about hyperactivity, the sensitivity of the airways to all kinds of stimuli, infection, which you can notice in daily life. The sensitivity to all these triggers, cold air, exercise, perfume, you can measure it in the lung function laboratory. So that's the standard test for that. Okay. So we have complaints and symptoms of asthma, which already can give an idea about the diagnosis, suspicion of the diagnosis. But we say, well, we have to sustain, we have to prove it by additional lung function tests. Reversible airway obstruction or a specific bronchial hyperresponsiveness, which are the two tests which can give extra evidence for the diagnosis. Well, something about the lungs and the airway, the lung function test. Here you see the anatomical slide. We have the trachea, we have the left mainstem bronchus, which is there are a lot of other smaller bronchioles until they come this very smallest part of the lungs, the alveolus, where the gas exchange is taking place. Well, this is the lung function. We call it the total lung capacity, the total amount of air which we have in the lungs. Now, first we asked the patients to inhale as maximally during the investigation, and then exhale as powerful and as powerful as possible. So the flow increases very rapidly and reaches a maximal flow, which is the peak expiratory flow rate. And then the flow decreases in the course of time until it's zero. the amount of air which is expired in the first second, we call it forced expiratory volume in 1 second. That's a very important lung function in these days. You can remember that. Forced expiratory volume in 1 second. And then we have the totally exhaled volume. We call it, does someone know how we call it? It's the vital capacity. It's the vital capacity. It's the total amount of exhaled air which you can exhale. And because it's measured during forced expiration, they sometimes put an F before it, forced vital capacity. You can also measure it during no forceful procedures. And then we have somewhat air in the lungs which is left, residual volume, which you never can exhale. Air in the alveoli or bronchioli, which you cannot exhale. So residual volume and vital capacity makes the lung capacity. Well, here a practical example of a child, let's say of 7 years of age, who has symptoms suggestive of asthma. This picture is a little bit turned by 90 degrees. Here on the y-axis is the flow, here the volume. And you can see these black lines, it's the predicted volumes and the predicted flows for this child related to age and to sex. You can see the child actually measured values are the red and the blue lines, so it's less than expected. So there really is a decrease in lung function. And the blue lines is without a bronchodilator, and the red line is with the bronchodilator. So there seems to be some response to the bronchodilator. If we look to the values, the FEV1 for expiratory volume in 1 second, we see that it is about 85% before the bronchodilator. That increases to 95% of the predicted value after the bronchodilator. So is this something we can measure in healthy children or in healthy adults? Some 10% increase in lung function? What do you think? No. You can have, let's say, 4 or 5% increase, but 10% increase is really big, and it's only possible in persons with this bronchoconstriction, which can be reversed by a bronchodilator. So we say reversibility for a beta-2 agonist with an increase in FEV1 more than 9% of the predicted value really is proof, perhaps a little bit too strong, but really sustains really the extra evidence for your asthma diagnosis, both in children and in adults. Yeah, here is the hyperresponsive, the bronchial hyperresponsiveness test, dosage effect curve of histamine, which we already discussed. Here on the x-axis, increasing concentrations of histamine. And here the decrease or fall in FEV1. If we go on with inhalation until there's a fall in 20%. Well, you can see in normal persons, there's never more than 10 to 20% fall, even not with the highest doses of histamine. Whereas in patients with asthma, they can respond much earlier, and also the maximal decrease in FEV1 is much larger. And the patient with the most severe form of asthma, they can go on with decreasing in FEV1. That's really, these are the patients with brittle asthma. That's very, very dangerous. These can be patients who can sit here and have no complaints, and they have a kind of viral infection or allergic trigger, and they, within 10 minutes they can have severe breathlessness because they can drop so much in lung function. So these are patients for the intensive care unit for the ventilator. These can be patients who really can die from asthmatic attacks, as illustrated by this slide. Can we diagnose asthma in children below 6 years of age? Well, that's a complicated topic. It's, we can go through this, why this is. Because asthma in children, there are different phenotypes. On this slide, you can see on the y-axis the number of children with symptoms, medication or somewhat decreased lung function. And here the age. Well, there's a substantial large group of children who have complaints in the first years of life, but they're symptom-free at the age of 5 or 6. There are children who start early with complaints in the blue line and who go on with wheezing after 5 years of age. They are not allergic, and we call it non-allergic asthma. They have bronchial reactivity. And there's a group of children who start very early with wheezing or other complaints. And they go on with having complaints after 5 or 6 years of age, and they are allergic. This is the classical allergic asthma. So you can see that there's quite a diagnostic problem at this early age. But how can you discriminate between these 3 groups of children? How can we know that it's episodic wheeze or viral wheeze as compared to more complaints who are chronic in old age? That is quite difficult. On this moment, we don't have tests to discriminate between these 3 groups. It's not possible by means of lung function or trying to develop new tests, but so far we don't have it. Well, this first group, this yellow group, who have transient symptoms, quite all kinds of terms or names has been used for this group. So the deep in the cycling, respiratory asthma, happy wheezing, all these kind of terms are not very lucky. Because these kids, although they have transient symptoms, they really can have shortness of breath, so they're not that happy during an attack. So in summary, the prognosis of wheeze and precox for children, it's important to realize that 40% of all children, so there's a huge group, has asthma-like symptoms, like recurrent wheezing or breathlessness. But the main part of it, 67%, is symptom-free at the age of 6 years. So these symptoms are mostly in relation to repeated viral infections. And 32% has persistent symptoms at 6 years and has asthma. So only the minority of children develop asthma. Also, at this university, we are very busy with developing new innovative techniques for diagnosis in these children. Here you can see a child with breathing, and we do all kinds of tests with the exhaled breath. You can condense it and then look for cytokines in it. We did that with the apparatus which was patented at the left side. You can also look for volatile markers of inflammation in exhaled breath, like nitric oxide, but there are others, a lot of mediators which you can measure. And we try by doing this to demonstrate this early inflammatory profile in these children, because we have seen that chronic airway inflammation is the basis of asthma, so there should be some way to demonstrate that these children have inflammation in their airways in a non-invasive way. Because it's not very attractive to do it in an invasive way. Of course, we can look into the airways by bronchoscopy and take some samples from the airways, but this always has to be done in children under general anesthesia. So it's really an invasive procedure, which also has its complications. So that's not very attractive. That's why these kinds of tests are very popular, very sexy topic of research. Well, what's the most important trigger for asthmatic attacks? Most exacerbations, most asthmatic attacks, a similar term for asthmatic attacks, is exacerbations. Most important trigger in both children and adults is viral infections. In children it's 85%, and in adults it's 60% of all asthmatic attacks. What should be the other triggers? So the first main source is viral infections. The second important source is someone from the back. Last row, also very clever people. What are the other triggers for asthma attacks or asthma complaints, which we discussed? Yeah, the allergens. Yeah, these are on the second place. So, exposition to allergens is the second important trigger for asthma attacks. And the non-specific stimuli, like cold air, exercise, perfumes, cigarette smoke, diesel, is on the third place, third main source. So we skip this slide. It's about breast bleeding. So how does the treatment look like? This is the kind of treatment which we use in children. It's we start when there are not many symptoms, and this also relates to adults. We start with beta-2 the bronchodilators, salbutamol. Let's say when there are, it's not more than 2 or 3 times a week there are complaints during for use, you can treat asthma simply by this bronchodilator. It's more severe than an anti-inflammatory drug. Well, the most effective anti-inflammatory drug is corticosteroids, like prednisone or prednisolone or dexamethasone. It's a very powerful inflammatory drug. And of course we give it by inhalation. Why should we give it by inhalation? He says it's specific for the lung tissue. That's true. But what is the advantage for that? For the rest of the body? You have your immune system already, and you can treat your immune system in specifically the lungs. That's true. But then the advantage is, people over there, you don't get a drug in other organ systems which you do not need an effect. So you have little side effects. That's very important, because when we give oral prednisone to you or to a child, what kind of side effects can we have after 5 or 10 days? Affects the liver, yeah. A moon phase, very good. The term in summary for it is Cushing syndrome. So moon phase, people start eating, they have increase in weight, in fat stored mainly here. Brittle bones can be earlier bleedings, pharmacists, gastric pains, a lot of side effects. So it was very effective. Immunodeficiency, because it's affects your immune system, defense against infections. So you can give and get herpes, viral infections, or varicella, pneumococcus infections. So it's a lot of side effects. So you specifically want to give it to the lungs. When that's not enough, we increase the dose of inhaled steroids. We have the possibility to give nowadays some long-acting beta-2 agonists, which have sustained 24-hour effect. They're very effective in reducing symptoms. So when asthma is more severe, you give it. And well, when it's not enough, we can give the asthma pill, asthma tablet. It's a Montelukast, a leukotriene antagonist. It's a drug which specifically inhibits the release of, not the release, but the effect of leukotrienes. Leukotrienes are very effective mediators of inflammation. They give also direct bronchoconstriction and also an increase in inflammation. And Montelukast inhibits the effect of the leukotrienes. When the drug was introduced, people were very high expectations, but we were a little bit disappointed during the next years, as we often see during the introduction of new medication. But the effects were very modest, and some patients you see no effect. Some respond well, only very little. So, and then for a very small part of children or adults who have very severe complaints, very severe allergies, we have the possibility to give anti-IgE, so therapy directly related, inhibiting the effect of allergic antibodies, anti-IgE. So there, you have to give it subcutaneously every 2 weeks, and it's mostly given in the hospital. So it's also very expensive. It's not attractive to give it in the general practice. So most of the children and adults can be treated very well with, let's say, the first 4 steps of this scheme. And when all these treatment steps are not effective enough, we end up with the prednisone given as an oral drug. But yeah, we have to realize that it has a lot of side effects, so we try to avoid it. Well, we already talked about it. The levels of asthma control are very important, and we divide it in very well controlled patients, partly controlled patients, and uncontrolled patients, dependent on the number of symptoms you have during the weekend. So there's a scheme for that. What's the time? It's almost 10:30. Well, a small word about some the development. About small particles. Are they really better? Because a lot of inhalers nowadays have very small particles. Now here you see the theoretical background about it. These are the airways at the left side of the adults. And when you inhale a drug, this only these small particles of it come to the lower airways, whereas now in children the airways are even smaller, so you need even smaller particles of the inhaled medication to reach the lower airways of the lungs. And perhaps that, when you have increased airway inflammation, airways are even smaller, so then the particles need to be even smaller to reach small airways. Well, here in this slide, in adults, they found out that particles, medication particles of 2 to 5 meter, very small, as the optimal size to reach both the larger and the smaller airways. But in children, probably should be smaller. Now, just to give you an idea about the deposition of the medication in the airways. Here is this is a very old drug, CFC BDP, and it's relatively labeled. So the red area is where the drug is actually deposited. It's mostly in the upper airways and only for 4% in the lower airways where, in fact, it should execute this effect. This is a somewhat more new drug, fluticasone, and you see that deposition in the lungs is somewhat increased to 30%, but still not very optimal. These are the smaller particle drugs, BDP, FIPB, which has really small particles, about 2 millimeter, and there's a lung deposition of 53% with these drugs. So this slide indeed demonstrates that the medication with a smaller particle size is really important in children. So we skip on some other slides of this. In conclusion, coughing, wheezing, and breathlessness are symptoms of asthma, but they are not very disease specific, as we have discussed. 66% of the children below 6 years of age with asthma-like symptoms have transient or wheeze, but they don't have asthma at a lower age. We have discussed the lung function examination in children and adults, that reversibility of airway obstruction as two agonists and specific bronchial hyperresponsiveness support the diagnosis of asthma, both in children and adults. We have seen that asthma is caused by several genetic and from environmental factors. And that hypertrophy or airway smooth muscle and chronic airway inflammation are the main pathophysiological features of asthma in the airways. And it's important to remember that inhaled beta-2 agonists and inhaled corticosteroids are the cornerstone of treatment nowadays. And by using these drugs, asthma is very effectively treated. It's almost not necessary to use their oral medication, oral prednisolone, for instance. We have seen that asthma has a huge effect on quality of life and the daily life situation. And good asthma control is essential for daily life. And we also discussed some studies that vaccination is only useful if you manipulate all risk factors. It's only one factor. Not only the house's microcouplings, but you also should attack the passive smoking in the house or the pets who are present there. So this was this lecture. Do you have questions? Is there someone who can start the internet here? I tried this, but